I request Dr. Arun Suraj sir to share his insightful knowledge on strategies for anti-ray aesthetics. Welcome, sir.
I should thank for getting this opportunity over here. I should thank Dr. Tillanagam sir, first of all, for giving me this opportunity. Being a private practitioner, I am not attached to any academics, I am not into any college, I don't teach, okay, I am not a academician, okay, I am a complete clinician. I just work, I document, and whatever I do, any clinical cases, there will be a theoretical backup in that. Okay, so I make sure there is a theoretical backup behind anything that I do. So that's why I feel, that's why I am here right now. Okay, so let me see if I can, inspire you, teach you something in this 1 hour, right? So what I'm going to talk about is these strategies of aesthetic dentistry. So we all know smile is an architecture, and for every architecture you need a proper plan and execution, right? So without proper plan and execution, your architect might fail. So as you see this image over here, what's gone wrong? There is a wrong planning, and as the saying says, anything you do should be well planned. If you don't plan well, things can get messed up. It's a very famous philosopher who said this. Can anyone say who is that? Pardon? Oh wow. Yeah, it's him. Okay. So sometimes comedians can give a very good philosophy. So we're going to see all the strategies that you have to follow for a proper aesthetic dentistry. First thing is attain patient's perception. Secondly, biomimetic principles in aesthetic dentistry. Third, photography and video protocols, guided preparation and isolation. These are the protocols that we are going to follow, and these are the things that we are going to see today. Okay. So we'll see all these are all these smile design principles. There are so many smile design principles. These are all there in your textbook. So I'm not going to go into each and everything, right? So as I always say that without knowing these smile design principles, one should not touch the aesthetic zone of a patient. Okay, no matter who you are, if you're an aesthetic dentist, you're a prosthodontist, you're a surgeon, orthodontist, whatever, you should know all these smile design principles. But there is something which is not there in your textbook. Okay, that is your patient's perception. It's not given in your textbook, but ideally, this is what something you should think about. When a patient comes to you for a root canal, right? You don't like the patient when the patient tries to boss over you by telling, doctor, you should clean it nicely, you should irrigate it well, obturate it correctly to the apex. We get irritated when a patient says that, right? Because we know our job. We don't want someone to instruct you how to do it. So that's a different thing. But however, when it comes to aesthetics, you have to listen to your patient. You know why? Because it's a complete optional treatment, and the patient decides what they want. Okay, and so you should sit, talk to the patient for a very long time. Only then you will understand whether this is the case that I can take up or not. Because there will be sometimes cranky patients also. They will just keep telling that, I want this, I want that, which is impossible for you. And that time you can also reject that case, right? In fact, I had a patient who came, she needed an orthognathic surgery, okay? So she comes, she sits and she talks so much, and finally she shows a photo of Tamanna. And she says, I want to look like this. Okay, she definitely needs surgery, I have to do a lot of work, and on top she is giving a condition that I will not do surgery, I will do only ortho treatment, that's it. Can I do that? It's impossible, right? So it's nothing wrong in someone expecting to look good. I'm not saying that it's wrong in what she's expecting, but when they don't give you the liberty to treat them in the right way, then it's not possible. So right away you can reject that case, right? So only when you talk to them for a long time, I can understand what she wants. Based on that, I can decide whether I should take up or reject, right? So always sit, talk to the patient for a long time to understand them really well. So if you see what are smile design means designing a smile that truly complements one's face and personality. That is known as facially driven aesthetics. So you design something, a treatment based on a patient's face and personality. Okay, so that is how this visagism concept came in. Visagism is not a new concept, it's in way a very old concept, it's there already, but this, after this DSD and all this came up, they brought this back to life. So it's nothing but the teeth size and shape are selected based on the morphophysiology of a patient. So you can either select an oval, triangular, rectangular, square, whatever shape you want. It's up to you based on the patient's personality, you can do it. So for example, a case like this, okay, he needs smile design. Obviously, see, this is the smile you're going to give him. Obviously, if you crop it and see, it looks ugly. No, it's so big, such a huge teeth. How is it going to suit? But this guy is a 6.2 footer. He's a very huge guy. And for a personality like this, I have to give him large teeth. But will my lab technician know that my patient is like this? I'm always just sending an impression, right? How am I able to communicate certain things with him? So this is for a case like this, I can make him decide what he wants, and this is a smile that the patient decides, and this is customized for him. So that this smile won't look good on anyone, but it will look good on him. Okay, that is a customized smile design. How do I decide this? Based on the patient's choice, because I already spoke about this test drive and all during my debate, right? So I do a test drive, I ask him how he likes it or not. So based on that, we can adjust it and bring it to a conclusion. Okay, so another thing, biomimetic principles in aesthetic dentistry is something that we have to follow. Okay, it is not chopping teeth, doing intentional root canals, grinding them, making them small and putting crowns on top. You have to follow a concept of biomimetic dentistry where biology, function and durability, everything is brought into one triangle. Okay, so that is what you have to follow. So the only simple way, what I will tell you, how you are going to do biomimetic, how you are going to mimic biology, basically for aesthetic cases, preserve enamel. Simple. We all know why we preserve enamel, so that you have a good adhesive, it has more of surface area to adhere well. That's one thing we all know. But other than that, enamel has a lot of function which you are going to see right now. Okay. So if you see, this is a macro image of a tooth. Okay. We have a cingulum, we have lateral ridges. So we should realize one thing, that the cingulum has the maximum thickness of enamel, and it is the most strongest part. It's the main reason for the core strength of your central incisor. And what do we do on this cingulum? We do an axis opening, we destruct it by making a crown, all those things, and even we chop off the lateral ridges so that a crown seats in well. So all these, just imagine how much of life that you are destructing on your tooth. Okay, this is what you have to preserve. So every time, if you see the purpose of a lateral ridges, every time it helps in guiding your lower centrals in position. Every time there is a protrusion and retrusion, there is the lateral ridges is the one that guides your centrals into position. So it in a way acts as a vertical stop as well. So now I don't want to talk more into theory, but just tabular column is something a little important, because you have to know the physical properties of your enamel and dentin. Any structure, you have to know this physical properties. Any restorative material, everything is compared with the enamel and dentin as well. You all know. So the modulus of elasticity, coefficient of thermal expansion, and the tensile strength. If you see for enamel, it is 80 GPa and dentin is 14 GPa. The coefficient of thermal expansion is 17 and 11. Tensile is 10 and 105. Now let's see which material is more or less near to these. If you see porcelain, it is 60 to 70 GPa, which is more or less near to that of enamel. You agree it's more or less near to that of enamel? But you see composite, it is 10 to 20. See the difference from composite to your enamel. So again, if you go to the coefficient of thermal expansion, if you see for porcelain, it is 13 to 16. Which is near to enamel. Again, composite is 20 to 40. Again, there is a lot of mismatch, right? You know, this coefficient of thermal expansion plays a very important role in most of the materials, because have you ever heard about zirconia crowns chipping off, the ceramic portion chipping off? That is basically because the coping of zirconia and the porcelain has a lot of variation in its coefficient of thermal expansion. And we never knew that. So we were always putting zirconia layer. You can do zirconia, but I always prefer to do a monolithic zirconia, because you don't have to layer anything on top of that. The porcelain is not a companion for your zirconia. So now they are modifying a lot in it. So that's a different story. But the reason why I think restorations fail is because of the mismatch in the coefficient of thermal expansion. So now this tabular column says porcelain is the best restorative the replacement for your enamel. Clear? Now you see this Ree et al. Study. These guys made a study in which they showed a recovery of 76 to 88% of crown stiffness after they restored it with a composite veneer. At the same time, they got 100% recovery of stiffness when they did a ceramic veneer. So can you believe that you can recover the stiffness of a tooth? Can it be done with a post and core? Impossible, right? We all just tell our patient that post and core is to strengthen your tooth. But ideally, we know as dentists, post and core is not going to strengthen the tooth. The post is just going to hold the core. But ideally, if you remember, see the studies which says that your veneer can actually increase stiffness. You know how? Because you retain the natural enamel. So these two little veneers can in a way act as a process to increase stiffness. So if you see your enamel, and an enamel shell is something which is really important in every tooth. So this enamel shell, imagine it is taken out. If you have removed this enamel shell, there is a study in which they dissolved this enamel shell alone and got only the dentin core. And what they did was they delivered a force of 5 kilogram on that, and they could see in the naked eye that the tooth itself was bending to up to 1 millimeter. Okay, so that resilient is your dentin. So every time, so just imagine you're already doing a root canal on that, and then you're putting a crown on the dentin, and imagine how much of forces are going to deliver on that, and imagine the resiliency. Then anytime you can expect it to break, right? So you know that when a tooth is root canal treated for 5-6 years, the dentin gets demineralized. So at that time, it's definitely going to fracture. So this is why this Okay, so now let me say, okay, like we're talking about biomimetic dentistry. We think only it is for the tooth which has a pulp, right? Because pulp is the only living organ, that's what we say. But imagine for restoring a non-vital tooth. Your pulp is not there, but you still have your enamel and your dentin, correct? Do you think the enamel and dentin does not serve that much? As I told all this time, your enamel has to serve in its stiffness, right? So you have to retain the enamel and restore it. So if you are all PGs, I would recommend you to please download this book or buy this. It's a nice textbook of Pascal Magne. Okay, it's about bonded porcelain restoration, the anterior dentition. His textbook will, if you read this, your perception towards restoring anterior teeth will change. Okay, it is he says, except in cases of endodontically treated teeth with severe breakdown, there is currently no evidence that contraindicates veneering a tooth. So it means you can veneer a non-vital tooth. Clear? It's because your enamel is more or less enough to maintain the stiffness of the tooth. So now we'll just see the cases. Okay, right? Hope you understood the biomimetic principles. So now if you see, okay, now I have a case. He's a 27-year-old male. He has a discolored central incisor, right? 1-1. So imagine what is the best material now I can do to restore this. So now he comes to me. He says, now this tooth is discolored. Can you change this for me? Now what is the best material? See his surface texture. See the shape of the tooth. Can I restore this with any processes? Is it possible? Ideally, I would say no. Let it be veneer or ceramic veneer or a composite, whatever. I cannot get the natural details back, right? So what I will do is, I got it back. What do you think I would have done? Simple. Non-vital bleaching. This is the best biomimetic way of treating a tooth. You don't have to chop it, you don't have to put a crown unnecessarily and damage the tooth. This is what I am trying to say. Whenever I say this in an IDA meeting or something, first thing some doctors will say, all this while we were doing zirconia crown and making money, now you are telling just bleach and send it off. How will you make that money? First thing is, this is what I say, charge them equally to a zirconia crown, that's it. Your neighboring dentist is not going to give this option at all, right? I am giving you a biomimetic option, so I will charge you equally as much as I am going to charge for a zirconia crown. That's it. So this is the only first biomimetic way you can think about restoring a discolored tooth. And another case, just imagine I have a patient who comes like this. He has okay, obviously if it looks like I can just restore it with veneers, but however these two teeth are non-vital. So he has comes with a history of trauma, and now I have to do root canals for these two. So how will I do? Already there is a defect on the labial aspect. So why would I again make an access opening on the cingulum and again damage the strength of the whole tooth, right? So what I do a labial access in this case instead of a cervical, instead of an access through the cingulum, I may do a labial access and I close it with a composite. I prep it for 2 veneers and just 2 veneers are there and I bond it to restore it back to its natural shape. So from here to here, and this is how the palatal portion is. So if someone sees this, they are definitely going to think, how did that gutta perga get inside, right? So you have restored it biomimetically and you have restored the strength as well. This is what you call conservative dentistry in endodontics, because I always feel when we call ourselves conservative dentists and endodontists, but however when you do endodontics, you are not conservative, correct? After that we have to put a crown. So we distract the whole tooth. So both doesn't go hand in hand. There are some ways where you can interlink conservative dentistry and endodontics, right? So how are you going to do your access openings? Why should there are many studies which prove that incisal access is much better, This is a study which says, in which they took 279 mandibular incisors, in that incisal edge, so in which they found that the straight line access was mainly only through incisal edge in 72.4%, and in the rest of 27.6%, it was facial of the incisal edge. So no studies said that it is more on the palatal aspect. Got it? So what are we doing always on the cingulum? Got it? So this is something we have to actually think about. Now another case, okay, we have a 67-year-old man, he wants to correct only his discolor tooth. Remember that. So as I said, when a patient comes to you for his smile designing, that's a different thing. You're going to give them smile design, right? But when a patient comes to just restore this tooth, do only that. Don't convince him for smile design. So when I showed this case in one forum there, one doctor said, why didn't you extract the mesiodens? Why didn't you close the gap and all? Patient is not coming to me for that. He's a 67-year-old man and he's happy with that. Why am I going to unnecessarily distract his tooth structure? So I ask him what he wants. He just wants this tooth to get back to color and shape. So what I do, as I already said, this is the preoperative state. I just do an internal bleaching, bring it back to normal. Now again, I have to restore the chip off, right? So what I do, I bevel, I etch, I place an adhesive. I use a putty index so that I have a good control over the palatal shell. I fabricate the palatal shell or a palatal shelf, whatever, and this is how the palatal shell is. And you can place a sectional matrix band, reconstruct the proximal wall first. Before the dentine layer, I actually add a dentine opaquer so that I block the line of demarcation, and then I go with a dentine layer, and finally enamel layer, and I cure it through a glycerin gel. You use a glycerin gel so that you prevent the oxygen inhibition layer. Okay, so I use a glycerin gel and I cure this, and this is how we bring it back to normal. Okay, just restored back to his edge. This is what he wanted. This is what we give him. Another case. This case I showed you during the debate. This is another young girl. She wants to restore her central incisor. She again same demand. She doesn't want smile design. She doesn't want to align her teeth. She just wants the 2-1 to look like 1-1. So what I do, as I said, I am doing a internal bleaching, but whatever I did, I could not get a very good result because the tooth surface was too rough. That's all I could do with my internal bleaching. So it's okay. I have somehow lightened the shade, okay, because if I'm going to place a veneer on this, my veneer, if it's a translucent veneer, it's going to show the discoloration of the tooth inside, right? So I have lightened it, and now I'm going to bond a veneer on this. So I just wait for 3 weeks because to permit proper bonding, and now what I do a prep all on enamel, just one single veneer, and I already told you how we communicate with the technician. We do a proper texture mapping, proper DSLR photography, everything is very important, and now this is the result we get. Okay, so can you see I've given enough time and enough details to my technician so that he can exactly match the processes, right? So, and you can see how well your gingiva has merged with your porcelain. So from where to here. Okay. So now, if we saw about biomimetic principles in a non-vital tooth, we will see about biomimetic principles in a vital tooth. So if it's a vital tooth, one of the principles says that if you have a little bit of chip off, you can still restore it with composites. Okay. So what I do now, the problem with composites is when you do a diastema closure with composite, what is the problem that we face? We don't get the proper emergence profile, right? I'll give you a small tip how to get a proper emergence profile. So if that is the problem, what I do is I first place a cord and then I dam it. A dam with a proper tie floss, and I push the tie floss much as I can, and I do a papilla compression. If you want to know what is the papilla compression, I'll show you a small video. I do a dam inversion first, okay, with a floss, tie floss. Dam inversion, it's better to do it with a tie floss. Push it as much as you can inside, and you can see the papilla is already getting compressed. I've placed the U frame upside down. I've placed it upside down, and now you can see I just pull the sheet as much as I can, and I lock it over the spike of my U frame. So you can see how much of compression that I am giving on my papilla, right? So now I am going to restore on this. I will roughen it and I am going to restore it. First thing what I will do is I will use a palatal shell using a putty index, as I already told you. I don't prefer BioClear because BioClear is a nice matrix, but sometimes what I feel is you will not be able to exactly know where is the midline is going to be placed, right? So that's the only drawback with the BioClear, but with a putty index, you can exactly calculate and place it as you wish. So that's one advantage. So I prefer a normal putty index. I do the palatal shell, and now I will just add dentin over this. Dentin layer over this. I use a normal mylar strip itself and I finish it. Okay, so this is it. This is the restoration, how it is, and you can see how well the gingiva is adapted to your composite, correct? So nothing, you cannot do better work unless you don't isolate it well. That's very, very important in restorative dentistry is what I would like to say. Okay, from where to here. And many of us think that, composites do not last. Composites won't last long, and it can fracture, it will discolor, all that. Ideally, if you polish a composite really well, polishing takes a long time. I'm telling you, if you do the proper polishing, you do it properly, if you get a nice smooth finish or a gloss like this, your composites definitely will last for long. Okay. And another case, a simple diastema closure. Okay, and now we are planning to do it with a veneer. I prep 2 teeth, I isolate it, I place 2 veneers. I fabricate 2 veneers. I isolate when I bond. So for isolation, I use a brinker. Brinkers are known as tissue retractors. Use them, proper dam, proper anterior isolation, and etch it. And this is how it is bonded. And this is not the moisture that you are seeing. This is again the KY jelly. As I said, the aqueous gel that I use when I am doing the final curing. Okay, so this is how KY jelly, and I cure it so that I don't get that discoloration around the margin in future. Okay, so always your final curing is done with a aqueous gel over it, and this is the finish that you get. You don't see any overhang or anything. Make sure floss is passed gently inside, and there shouldn't be any resin cement that is being overhanging inside. Okay, from where to here. Another case of dental fluorosis. If you see this, okay, now this guy has come, he has spacing, he's got fluorosis again. Now what I do, now when you have fluorosis, don't jump into conclusion, oh, I have fluorosis, I cannot place a veneer on it, veneer is not going to bond on a defective enamel. Don't do that. The best way is first to prep and decide. Go in a very conservative way. What I do is I will prep and decide whether I have quality enamel to bond on this or not. So if this is like this, this is the design that we do, how we want to get it, and this is the digital template what I have done, and now I am doing a prep on this. Okay, I made 0.5 mm depth cutters labially, incisively 1 mm, and now I just remove all the enamel. So when I remove the enamel, this is what I have. I have healthy enamel. You can, how do you find if you have healthy enamel or not? You can scrape it with a sharp probe, or you can slightly gently etch it for a while and dry it and then check wherever it is frosted. So based on that, I check whether I have a good frosty enamel. Yes, I have on all. I have a good enamel, and only on this canine cervical margin, I have a little bit of dentin catch. This usually happens for most of the veneer preparation on your canines, because patients generally they come with a lot of abrasion on the canine, especially on the cervical area. So that area, what do I do now? I can do something called as an immediate dentin sealing. I do a IDS where you can still, hold on that hydrated collagen fibrils, and you maintain that hybrid layer, and you can improve the bond strength of your resin cement towards that area of dentin, correct? So, and the second best advantage of an IDS is you will prevent post-operative sensitivity, right? So, you have two options. Then the IDS is, I think I even spoke about IDS a lot recently in Meenakshi. I think many familiar faces over here, so you must be knowing. This is what you can do, and now I fabricate 6 veneers, and all are bonded one by one. You isolate, proper isolation, anterior isolation, etch all together. When you are bonding, bond one quadrant first, and next bond the other quadrant. Keep one of the veneer as a control and bond the right side, then bond all on your left side. Okay, so this is how it is once everything is bonded, and once you finish complete bonding, make sure your floss passes in properly. Okay, your floss should pass in and out, and you should not have any obstruction, no resin cement left over there. Okay, so that's very, very important for after you bond your veneers, and this is how it is. This is an immediate photograph after I have finished my bonding. So you can still see a little bit of papilla that is not filled in between, because this is an immediate post-op. So I call the patient back after 4 days. So after a 4 days post-op, you can see how well the gingiva has merged with the porcelain, right? So we have a happy patient here from where to here, right? So we'll talk about guided preparation. So to talk about, there are other names also. It's called guided preparation. You can call it APT, which is aesthetic pre-evaluated temporaries, or Gurel's technique, because it was named after Galip Gurel. Galip Gurel is a very famous prosthodontist, and I had a privilege to learn this APT technique under him. It was a one whole day course, but I will try to explain you as much as I can. It's pretty easy to understand. So what is nothing but fabricating a mock-up, doing a mock-up and prepping through that, so that you don't, if in cases where you have malaligned teeth, you don't have to prep unnecessarily on all the teeth, correct? In case you have one tooth which is placed inside, palatally placed, and the other one's a labially placed, you don't have to prep more on the tooth that is positioned more palatally, right? So because you can make it as a non-prep veneer on that. So that is what, that's the advantage of using an APT over it. So what I do, I can either do a direct mock-up or I can do an indirect mock-up. Direct mock-up, I will do a composite on that. Indirect mock-up, I can use a bisacrylic material, either like Cool Temp or a Pro Temp, Luxatemp, anything. So this is an APT. If you can understand this diagram, it is nothing. If this green line is where you want your veneers to be positioned. Okay, if this malaligned teeth has to be positioned along that green line. What you do first is you will do an APR, or that is an aesthetic pre-recontouring of the teeth that is slightly jutting out. That red portion is the one that I have chopped off. I do a pre-recontouring, I remove that off, and wherever that blue marking is there, that is where I add a composite on that. I do a composite mock-up on that, so that now I have leveled the teeth to the position where I actually want it. Got that? So now I have done the leveling, and this is going to be my final position of after I bond my veneers. Now I will prep through this. Okay, I'll place my depth cuts over that, I'll remove the enamel over that, and so that certain areas where the composite is there, I would not be touching the tooth inside. Got it? So I can make my preparation as conservative as possible, and at the same time I have a very predictable outcome. Got it? Because I have predetermined where my position is going to be. So we'll see another nice case. Okay, this lady she's 47-year-old. Obviously, we might think, okay, 47-year-old and what aesthetics they want. It's not like that. Many of them really love to look beautiful even if they are above 50. So imagine this lady comes to me and she comes telling, I am the fifth or sixth, I am the fifth dentist, and 4 dentists previously have told her. What would they tell? Yes, intentional root canal, canine to canine, and do crowns. Correct? So I told her I will still try the best conservative way I can. So I planned for veneers on all, because when I did, this is how it is. So if you can see, I feel the laterals are more placed inwards. So if I bring the laterals outside a little and the central slightly inside, or if I slightly tip them a little, won't I achieve what I want, right? So I thought I don't have to aggressively get into this case. So I thought, okay, so let's do a proper digital design. I just do a outline. I place an outline to imagine how I'm going to bring it. So this outline shows that I have to add more of porcelain on my laterals, and definitely I have my centrals jutting out. My incisal length is pretty more. So this is the template when I've done it. So what I do, with this image, I decide to do an APR on my incisal edge of my centrals. I've done the APR, I've done a little bit of APR more on the label surface also. Now what I've done is, I have done a composite restoration on that. I've actually added, I've added composite on this and closed the spaces and everything. And on that, I have reduced the tooth surface or structure also. I am asking the patient every time if she is okay with this or not. So every time I reduce, this is the position I get. So finally, this is the position and the patient is happy with this. You can see a lot of burr marks. That's okay. This is just a mock-up. So what I do, now I prep through this mock-up. I place my depth grooves in this mock-up. I do my pencil markings on that. And now what do I do is, I just take out my composite mock-up, whatever is done. So once I take out, can you see where all the pencil markings are not there? Can you see that on the laterals, you don't have any pencil marking? That means I don't have to prep on the laterals, correct? I don't have to prep on the laterals. So I can make the laterals a little prepless. I have to prep more on my centrals and canines. The laterals alone, I can do a little bit of, I can just define the finish line as well. I have done a little bit of crown lengthening on my laterals. You can notice that. I can do a little bit of crown lengthening. All I have decided with my mock-up itself. I use a mock-up itself as an outline, and you can do everything, right? And then finally, now this is my prep. So can you see, most of my prep is on enamel itself. I've retained enamel. I'm still staying on enamel. As I said, mostly in the canine area, you will always expose a little bit of dentine. It's okay. I'm more of enamel in many of the cases, except for the canine. I do an IDS over there, the left canine. And finally, I fabricated just 6 porcelain veneers and all bonded veneers. And this is the final post-op. So you can see how she's smiling. This is how she was, and this is how she is. We have done a very good transformation, but just veneers. Okay, it's not about treating her, not about making her look good. We can do it. If we just chop it off, do intentional root canals, you can do our root canals and crowns, but we have restored it biomimetically. That's what we want, right? This is how it is, and how it was, and this is how we got it. And another case, this is a 36-year-old girl. She wants to do a smile makeover, obviously somewhat similar to that, but not as bad as that, but she has a diastema. Obviously, when you see her, you can decide what she wants, right? You can decide the plan what you want. You can see the left canine is slightly jutting out, the right canine is inside. So what I do, I place a small design. I can understand that this canine has a lot of excess bulk on the left side, and on the incisal edges of my centrals are also pretty long. So I do my APR. I do a very calibrated APR on my incisal of my central incisors, and then even I do an APR on the canine bulk of my left canine. Okay, so now when this is done, I can just assume how my how my finish is going to be. So after my APR, this is the impression that I take, and this is the impression I send it to the lab, saying that this is my diagnostic or a preoperative model. Okay, with this he has to calculate how thick he is going to make the veneers and all that. So from this, This is just a rough outline how my APR is, and now my technician has done a wax mock-up for me. He does a wax mock-up on the APR model and he gives it to me. So what I do, I take an impression of that, I go to a putty index of that wax mock-up, and I just, as I showed you earlier, we cut out the excess, and then I just add this acrylic material and I transfer it into the patient's mouth. Now this is how it is when it is indirectly transferred into the patient's mouth. Now what do you think the patient is going to tell me? Now will she be happy with this or not? She may not be happy, because she might definitely find her central a little bulky, because the wax is added and we have just transferred it. So I let her decide. So she wants to reduce more on the central. So what I do, I directly with my burr, I reduce more on that. When I am reducing, yes, I might reduce a little bit of tooth structure as well. That's okay, because anyway we are going to prep on that. I reduce it and I ask her if this is okay with her. This will, when she says yes, that will be my final position. You got this point? So that will be my final position, and now through this I am going to prep my veneers, and I'll show you this transformation in a small video. This is how she comes to you. Always take a video before you plan any case. I'll tell you why. Talk about some cases. As I explained you the digital outline, and you know how to do the APR. So I do the preps directly on the APR, okay? And this is my final prep. I place cards, I take impression, and this is the transformation. And now you understand why we take a video before and after. Can you see a lot of change in her? There's a very big different change in her. I'll show you. Can you see her hair color? So if you see, she's done a hair coloring after the treatment. I call her 1 week later just for a for the photographs and the post-op video and all. The patient has changed her whole hairstyle, her dressing sense, everything. You really feel happy when a patient's whole attitude changes, just after an ordinary smile makeover. So just imagine how much it has to do with the patient's psychology. Okay, a bad smile really puts them down, and if you improve it, you don't get any happiness other than that making a patient happy. Okay, so what I'd say, I already spoke about this. You need to invest a little bit on photography to do good work, to improve your work, to communicate well. So if you have interest in photography, please, I would say, don't think about the brand, either Canon or Nikon, any brand would do. You have to have a macro lens. You need a 100 mm macro lens. Your camera body is only going to cost you 25,000 to 30,000. That's it. Your lens will be expensive. You have to invest on a good lens. That you need is a 100 mm macro lens if it's a Canon. If it's a Nikon, you'll have to go for a 105 mm macro lens. Okay, so flash. Without flash, there is no photography. Photo means flash. Photo means light. So if you have to, you can invest either on a ring flash or a twin flash. The only difference is twin flash, you can detach it, a ring flash is constricted over there. So the twin flash is pretty expensive. So maybe initial to start on, you can start with your ring flash and later on shift to twin flashes, right? Okay, another case, it's a very old case of mine. Why I was telling you, I do the video documentations, because every time you take, as even sometime back we were talking about it, you will get to know how the patient is exactly going to smile only if you take a video. Only a video documentation will exactly give the expressive smile of the patient. Most of this demotivated, that is patients who have a very demotivated smile, they will not show their teeth. Even if you ask them 100 times to smile, they'll give a very restricted teeth. That's all their smile will be. So it's very hard to get that a natural expressive smile out of them. So when you talk to them, just crack some joke in between, just talk something, and every time you say something, suddenly they will laugh out. They don't laugh usually like this. Okay, they will laugh only when they're comfortable, they're in a different, with their friends or something like that. So when you talk to them, you will get that exact expressive smile out of them. At the same time, you can also listen to their words, listen to them, what they exactly want. So you can decide on your treatment very well. So when I keep talking to her, when she smiles, at that point, I will freeze that. I freeze that smile and I decide now how I'm going to do the smile makeover for her. So now I know I have to do gingivectomy here, when is all that. So this is giving you an idea how I'm going to go about. So after that, I can show her a video how to show you. We'll know how the transformation is done. You can see she's got a beautiful transformation, and I can make her appreciate that by showing her before and after video. So this is one thing you can make the patient happy as well. At the same time, I can use the same video to convince another patient, right? If I show another patient who's coming to me for a cosmetic treatment, I don't have to talk so much unnecessarily. I can just show this is what I do. So the talking part, the convincing part and all is drastically reduced in my practice especially. So this is how she is, okay, after the makeover. And what I would like to say, many of us, who, it's a small advice that I'm giving you, because we all think, I missed to become a doctor. I should have become an MBBS. I would have become an ophthalmologist. I would have become a cardiac surgeon. I could have done that and all this and all that. Stop blaming, because you have to be blessed to be a smile maker. Okay, this is what I would like to tell you. And because, as I already said, you can change lives, and there's no happiness other than seeing someone being happy just because of you. And the only success way to deliver a successful restoration is to balance aesthetic function and durability. That is only done if you can mimic biology. And if you are really concerned about the longevity or the success rate of a porcelain veneer, you see these studies, these rates will show you. These are studies which are done from 94 to 2005. 93% of success rate, 95% of success rate on an average at that time. Which we don't have that success rate even for our root canal at that time. So something was going wrong in the way we were handling veneers. That's why in India we always say, oh, veneers don't last, veneers will chip off, veneers will debond, all that. Ideally, it will stay like anything. Okay, so start changing your perception towards dentistry. And I've conclude by saying one thing: success is no accident. It's hard work, perseverance, learning, studying, sacrifice, and most importantly, love what you are doing. If you don't love your job, if you don't like to do, if you don't love your work, I would say you can actually quit. It's really hard to stay in a profession where we don't like it. So start loving your job and just start working for that. You'll really be a successful dentist. Thank you so much for patient hearing.
Thank you so much, sir, for delivering such a glittering presentation. Thank you, sir.
Fantastic lecture as usual. I know him personally, so I know this is how it's going to be. That's why I asked you all to stay back. So hope it was worth it, isn't it?
Any doubts? You can.
Any questions?
I know it's too late for you all. You all have to travel back so much, but still, if you want, you can spare a little more time.
Okay. So before I hand it over to the organizer, just 5 minutes of time, sir, so that I can speak something. First of all, I'm going to do something what you see in Vijay TV, how the judges immediately after somebody outperforms, they immediately get up, go hug. So that's what I'm going to do. So I want to tell you something. We both have grew up almost similar. We have UG batchmates, PG, just 1 year, senior, junior, like that. So we are just like each one of you, how each one of you are at this stage. So whatever we are, I'm not saying that we have achieved something great, but whatever we are, it's only because of, you can see the passion behind, right? And you might always complain, my college doesn't have this facility, it's not providing me this, that. Guess from where he learned all this? Do you think he learned all this in PG days? So each one of us here, we keep learning after PG. So he goes to so many places, he buys the cameras, he must have done a lot of clicking or by himself or his attenders. That's how they learn. The learning is it's an endless process. Okay? So I hope you all got inspired from this program. Why I took the mic now is the organizers are here, nobody is there to thank them. So I thought I will do that because Thilainayagam sir, I know that every time they organize, I always feel that they work as a team together. So it's completely dedicated. When it can be easily seen in the organizing, you can see that if anybody is doing it without, if they don't like it, you can easily make it in their faces. When I reached, it was 4 o'clock in the morning, and already Dr. Kaushalya kept calling me till 10 o'clock, 12 o'clock, 12 o'clock, then around 2:33 whether I have reached. She was afraid that I might reach and get stranded, so they didn't even sleep. The next day morning she was here, and again the same thing with Srini, a lot of other people whom I don't even know the name, the PG students, they worked really hard for it, really, really hard for it. So they really deserve a big round of applause. And as Candice has said, fantastic audience from yesterday. It's not an easy place to reach, but still, he was really afraid. He was telling me, second, last lecture, I don't know how many people are going to be there, because you have seen the efforts that they put in. The best they want is at least a lot of people to get inspired by that. And you all stayed back, you all felt you were absolutely silent. I could make it out that you're really attentive. So I think you take back a lot from this program. Thank you so much.
Thank you everyone. As a organizing chairman, I thank all the delegates who come from far and near from the institution. And I want to give you one note, that is, after this prize distribution, please be here. I want to be with you all with one group photo. So don't leave the hall. Be here another 5 minutes. We will make a group photo. Thank you.
So please felicitate Dr. Arun Suraj sir. Thank you, sir. I request Dr. Thilanayagam sir to please felicitate Dr. Abhrajidan sir.
Of today to add golden feather in the hats of success.
Now it's time to acknowledge the talent of our brimming buddies by beginning the prize distribution ceremony.
Do you feel some turbulence around you, Dr. Vaibhavi?
Yes, doctor, I do agree.
The heartbeats have gone up and everyone is eager to know the results. Well, here we are with the results.
Before that, I would like to announce the sponsors of our event. The prize money for the category Restorative Dentistry is sponsored by the Dentsply, and the prize money for the category Endodontics is sponsored by the K-Walker Company. I humbly request Dr. Srinivasan sir to kindly announce the prize winners of the day.
Good evening. Coming to Restorative Dentistry category, the second prize, which is sponsored by Dentsply, goes to Sri Ramachandra Dental College, Dr. KVN Shruti. Her topic is bioemulsion, a conservative way. And Restorative Dentistry first prize, sponsored by again Dentsply Sirona, goes to CSI Dental College, Dr. M.R. Pradeepa. Her topic is Adios to conventional restorative techniques in fractured anterior root-filled teeth. Coming to endodontic category, the It is sponsored by Coworker. The second prize goes to Meenakshi Ammal Dental College, Dr. Darshya Sweta. Her topic is on Vital Pulp Therapy, a case series. And first prize sponsored by Coworker. Definitely this guy would be expecting prize. It's from JKK Nadaraja, Dr. Prem Kumar. His topic is on condoms in apexification. And this guy has presented in both operative dentistry as well as endodontic category. He really presented very well and both the judges appreciated him and he deserves this prize. I need a big applaud for him. And it was a tough selection by the judges and it was completely blinded. So judges won't be knowing which college you people belong. So I really congratulate you all. Thank you.
இந்த லாஸ்ட் தெரியல பட் நல்லா ஃபார்வர்ட் வாங்க ஃபோட்டோ எடுக்கிறதே தெரியுது தான் சரி சார் நல்ல ஸ்மைல் ஃபுல்லாக இருக்குங்க ரெடி சார் கார்த்தி சார் கொஞ்சம் நீங்கள் மேலே இருக்க
Sound early.
Satish, ரெண்டு கை ஸ்மைல் நல்லா சிரிச்சுட்டு ஓகே